Hello, my name is Emily Richards. I'm a recent graduate of Magnificat High School and will be attending College of the Holy Cross in Worcester, Massachusetts in the Biology Pre-Medical program next year. I worked in the Science Internship program this summer in the Emergency Department with my mentor, Dr. Sharon Mays. The title of my project is The Initiation of a Rapid Response Team Decreases the Incidence of Codes and Improves both Initial Survival and Survival to Discharge. Firstly, a rapid response team was first developed to respond to acute changes in a patient's condition. The purpose of rapid response teams are to decrease the number of codes outside of the intensive care unit and to improve patient outcomes. So codes is short for a code blue, which means that the patient is unresponsive, not breathing, or pulseless. The Cleveland Clinic has their own rapid response team called the Adult Medical Emergency Team, also called AMET, which was established in January 2008. AMET has expanded its work to respond to all medical and surgical inpatient floors in the entire hospital. So AMET is comprised of a 3-member emergency team, which consists of a nurse, a respiratory therapist, and a physician. Their primary duty is to respond to the patient's location within 10 minutes of being paged. If you are a hospital employee, you can actually activate AMET by dialing 122. So to prepare for emergencies, AMET carries 2 bags containing emergency medications, respiratory supplies, which would include intubation equipment if that was necessary, intravenous line setup, and point-of-care testing via a portable rolling luggage cart. So AMET can be called for a variety of different reasons. One would be acute respiratory, cardiac, neurologic, or blood pressure changes. Another could be if the respiratory rate was below 8 or above 32, if the pulse oxygen saturation was less than 90%, if their heart rate was below 40 or above 140 and they were showing symptoms, or just if their heart rate was above 160, if their blood pressure was above 220 and they had symptoms, or just if their blood pressure was below 80, if they seemed to have chest pain with ECG changes, or if they were unresponsive to nitroglycerin, if they seem to have a change in their mental status, if they lose consciousness, if they feel lethargic, if they have a new focal weakness or a loss of movement, or if they suddenly collapse. My hypothesis is if a rapid response team is initiated, then the incidence of codes will decrease and the initial survival rate and survival to discharge rate will increase. So for my methods, the total number of the non-intensive care unit codes and survival rates were compared for the year prior to AMET, which would be 2007, to the first year of AMET, which would be 2008, from the months of January to June. And the survival rates that were compared were the initial survival and the survival to discharge rates. And it is important when we are looking at the graphs that are coming ahead that we realize that AMET started responding to changes in a patient's condition, which would be non-codes, in January 2008, and they began responding to codes in April 2008. And then also true CPR events were defined as no pulse and no respirations. So in Figure 1, we have the number of codes for the inpatient floors graphed. The blue would be the 2007 codes, so that's pre-AMET. And then purple, we have the 2008 codes, so that's after the initiation of AMET. So we see that the incidence of codes in 2008 was less than the incidence of codes in 2007 for all of the months that were studied. So that shows that AMET was successful. And if we look back, we see that in March 2007, there was an unusually high increase of codes, and that's because the incidence of acute infectious diseases such as pneumonia greatly increases during this time. In Figure 2, we see the initial survival for inpatient floors. Again, blue would be the 2007 codes before AMET was initiated, and then the purple 2008 codes after AMET was initiated. So we see that the survival rate in the inpatient floors in the first quarter of 2007 and the first quarter of 2008 show no significant differences. And there are a couple reasons for this. Firstly, because AMET first began and became organized in January, which was quarter one of 2008. So people were just beginning to become accustomed to the system of calling AMET when there was an emergency. And also during the first quarter of 2008, AMET was only responding to changes in a patient's condition, so non-codes, like I stressed before. But then in quarter two, April 2008, AMET was responding to codes, so that would be your unresponsive, pulseless patient. And also in Figure 2, we see that there is an increase in the survival rate after the initiation of AMET, excluding quarter one for the reasons that I mentioned before. So Figure 3, we see the inpatient survival to discharge graph. Again, blue, 2007, that's pre-AMET, and then 2008, the purple, that's post-AMET. So we see that after AMET was implemented in January 2008, their survival to discharge rate increased by approximately 10% between quarter one and quarter three. And as AMET gained more experience within 2008, the survival rate and survival to discharge rate increased. And also when we look at Figures 2 and 3, there is a significant difference between the initial survival and the inpatient survival to discharge between 2007 codes and 2008 codes. So in conclusion, the hypothesis was supported by the data. Due to the use of the rapid response teams, such as AMET at the Cleveland Clinic, the incidence of codes decreased and the initial survival rate and survival to discharge rate increased. Although AMET began gradually during 2008 and there was an adjustment period, even during the early months, there was a decrease in the number of the true CPR arrests, which we saw in Figure 1. There was improved initial survival, which was present in Figure 2, and also improved survival to discharge, which was seen in Figure 3. Also, there was a trend towards fewer codes in 2008 during the later months than during the earlier months, and also improved initial survival and survival to discharge during the later months as well. And that's because AMET began responding to more and began being more accustomed to their patients. It is likely that the monthly trend toward improved patient outcome with fewer codes and improved survival reflects the gradual initiation of AMET from just a few areas to the whole entire hospital, covering all medical, surgical, non-intensive care unit inpatient areas in the later months. So overall, the initiation of a rapid response team, such as AMET, resulted in a decreased number of codes outside the intensive care unit and an increased initial survival and survival to discharge rate. So I recommend that the patient's exact time difference that it took for AMET to reach the patient should be studied, because time difference could greatly affect whether the patient codes or not, how long the patient survives, and even how long they survive onto discharge. So I feel like even though AMET's primary duty is to respond to the patient within 10 minutes, the exact time difference can make a big difference, so that should be studied. I also recommend that drug testing on drugs that could support the life of critically ill patients in emergency situations be tested and used further, because it has been proven useful, but it may decrease mortality rates even further if we expand the practice of them. And then also a process of streamlining and transferring the patient to specialized areas should be made so that the patient's specific needs can be met outside of the emergency department. I would like to thank my mentor, Dr. Sharon Mays, and also the Cleveland Clinic Office of Civic Education Initiatives for giving me this opportunity.